Thank you so much. Yes, I'm Rachel Smalley. I sort of describe myself these days as a recovering journalist, now working really in strategic communications and storytelling across largely the health sector and primary and secondary care. Over the last 4 years, much of my focus has been on Pharmac. I set up the Medicine Gap back in 2020 with the arm's length support of James and Cecilia Robinson and also Dame Teresa Gatting. We saw a need with the number of people that many of us were supporting on Give a Little, and we knew that we could be doing better than what we were. So that was a 6-week campaign that began in 2020, so that all worked out brilliantly 4 years later for me. I say that tongue-in-cheek. It's been a remarkable 4 years, but I think we're at a space now where we've got Pharmac to a point where it's certainly on the edge of change, I think, looking to modernise its approach to valuing medicines and considering medicines through an all-of-society lens. I was buoyed to hear Lester Levy then talking about some of the organisations within health. We need to have porous borders, and that certainly applies to Pharmac and measuring value and what value it can bring to the health system. There are many in this room who will say if we invest more in primary care, then we can spend quite a bit less on Pharmac, and I would 100% agree with you. The stories that certainly come through my website still at the Medicine Gap are of those who arrive, particularly Māori and Pacifica, at the doors of our A&E with late-stage terminal cancer, and that is their first touch of the health system. We invest more in primary care, more in screening. As you all know, I'm preaching to the converted here, then we can certainly create some value and improve productivity and elongate and enable lives throughout New Zealand. Part of that primary care is, of course, mental health. And the next 3 speakers, we've got 3 quick-fire speakers for you in this space today, will be speaking to this issue. I'll invite 2 up onto the stage if I can. Rachel Brown and Dr. Frances Hughes, if you could take a seat up here on the table, on the chairs next to me, please. Our first speaker is the Minister for Mental Health, the Honourable Matt Doocey. He has worked in both mental health and healthcare management here and in the UK. He studied counselling psychology at Welltech. He has a Bachelor of Science in Social Policy, an MA in Healthcare Management from Kingston University in London, and a Master of Science in Global Politics from Birkbeck, I think also at the University of London. Ladies and gentlemen, please welcome to the stage Minister Matt Doocey.
Kia ora koutou, tēnā koutou. Lovely to see so many familiar faces here and a lot of new faces as well. And I'm just reflecting on that speech from Lester and wondering how he can stay so cool and calm. I want his mindfulness techniques because they are clearly working. That man has a huge job, but I'm sure you'll agree after that speech, he is the right person. Look, I've been asked to talk a bit about my views on localism in mental health. It's always a bit interesting when you're asked to talk about your views and you've got media in the room as well. Let's see how that goes and what comes out of it as well. It's always a bit edgy. I'm quite well known for going slightly off script, but that's good. That's what we want to do. We want to have a good discussion. First thing I'd say, as New Zealand's first Minister for Mental Health, it's a real privilege. But let's be very clear, nothing has changed because I've got a job title, right? Nothing changes because you give someone a job, but clearly how we use this role for my part of the system in the next 2 or 3 years, hopefully we can drive results. But clearly we need an all-of-country response, and that's why we need to make sure everyone in this room plays their part as well. So just want to acknowledge Rob from NIB and Oliver from the New Zealand Initiative and your respective teams, and Michelle, who's got Olympic gold on today, I see, for organising what will be another brilliant day. The reason I advocated for this role was I don't think Maria English is here yet, but when we went into opposition, Bill was our first leader. I say first because, as you know, we had a few. And I went up to him as a new MP and said, Bill, I think it's about time we had a standalone mental health minister. Because clearly health ministers of any political persuasion can get very distracted on physical health. And I thought it was about time we had someone who could focus solely on mental health. We looked around the world. Some have gone down the route of ministries. We didn't think we should do that. We thought that would silo mental health more. But Australia moved to the model about 6 years ago, and it seems to be getting results of having a standalone mental health minister who's responsible for the mental health ring-fence funding. And I might surprise you when I say this year, the mental health and addiction ring-fence funding will be $2.6 billion, right? Last year it was 2.4 with the uplift in budget 2024. That's a significant amount of money. And so clearly times are constrained economically at the moment. So I know myself, and it's been made very clear to me by the Finance Minister, Nicola Willis, is that before we go to her through any budget bid process, we've got to be pretty confident ourselves as ministers that we are deploying our current budgets in a way that maximises outcomes and effectiveness. So I'm really keen to get into that 2.6 billion and understand how we can prioritise that. And that's why I think the day like today is brilliant. Because when you think of mental health, look, a hip replacement in Christchurch is pretty much the same as a hip replacement in Auckland. And many in the room will know that. You're nodding your head. I would argue how you respond to mental health in middle-aged dairy farmers where I live in Rangiora, Waimakariri in North Canterbury will be potentially quite different in how you respond to mental health in young Māori in Auckland. And that's why I think the centralising of healthcare over the last few years in a mental health frame, I think, is potentially quite dangerous. And I think we need to return to a devolved model and look at how we can support local communities, because I think it's local solutions for local needs. And that's why I really welcome this conversation today as well. Another key part of my role as well has been responsible for that budget is to drive what's called an all-of-government approach, and I'm sure you'll agree it's not only about how we support better mental health within Vote Health, but what am I doing with, say, Erica Stanford within education, Mark Mitchell, police and corrections, Chris Bishop, Tamapotaka in housing. And I think mental health can be a valuable input to reaching their goals, and I'm looking forward to developing that side of the work. And for me, I do have a wee giggle from the young boy with mental health issues, which largely resulted in some pretty dark times in my life, but resulted in me reaching out, not initially, because I, of course, knew it all, and I was a young male, used to play rugby and drink a lot, so I wasn't going to ask for help. But when I finally did, that really changed my life, and more in the sense as I wanted to do that person's job. So that's why I trained in mental health. And I was very blessed to go and work for 15 years in the British NHS and worked in the front line in the East End, in the borough of Hackney, and anyone who spent some time in the East End knows that if it doesn't happen in Hackney, it never happens at all. It all goes on there, but it gave me a great insight to the understandings and also a centralised health model, which when I left the NHS, they were moving towards a devolved model, and I arrived back in New Zealand and we were moving towards a more centralised model. But what I would say is when you start to think about localism, and especially subsidiarity of making sure you are making decisions at the most local level you can. And I think there's actually real opportunities for that. If you look at, say, the inpatient facilities for eating disorders, there's an argument to contract them nationally. I think when you look at our specialist services, I think the devolved model that Lester articulated around the 4 regions could be a way of delivering those. But actually, I think there's even potentially a more local level. And if you think around council jurisdictions and councils might be an ability to really deliver some local solutions for local needs. So when I was in the NHS, many will know they've devolved a lot of their budgets for health and social care to a council level. They had programs which I work closely with called the Drug and Alcohol Action Teams, and they were responsible at a council level for mapping out the needs and then identifying the local response to address their drug and alcohol addiction needs in their local communities. And what I call that is national consistency and local flexibility. And I think there's a real principle that we can apply across mental health is setting national standards, but allowing that local flexibility of the types of needs specifically within that community and the types of service provision available. So in this new role, we have set out 4 clear priorities, right? The first one is increasing access to timely mental health and addiction support. And I think you'll agree after the inquiry, it's a big need to grow more access. The second one is growing the mental health and addiction workforce. And that is linked to the first priority because a large reason people can't get into the services is because there's big workforce gaps. I visited a service in Wellington recently, community adolescent service, 50% vacancy rate. So it's quite obvious why people are stuck on waiting lists and can't be seen. The third priority is strengthening focus on prevention and early intervention. So we've got to do a lot more upstream. So we're not waiting for people to get into crisis. And the fourth priority is improving the effectiveness of the services that we are funding and delivering. So alongside of those 4 priorities, the Prime Minister and myself announced 5 targets. First time we've had targets in mental health in New Zealand. They're now within the GPS and the health plan. Some of you might have seen them. The first one is 80% of people to access specialist mental health and addiction services within 3 weeks. Now, I met my counterpart in Scotland recently over Zoom, the mental health minister, who congratulated me on them because she went on to tell me the government target for specialist services in Scotland is 18 weeks, and we've just set a target for 3. And I just said to her, I don't think the New Zealand public would allow me to set a target of 18 weeks. Primary mental health and addiction services, we've set a target of 80% to be seen within 1 week. We've got the mirroring of Shane's target, around 95% of people to go through ED within 6 hours. We've created a target that we're going to train 500 new mental health and addiction professionals every year. Currently, we train 423. We're going to go to next year to 500 out of baseline. No extra funding. That will come out of existing baseline. And then the 5th target is out of that 2.6 billion, we're going to ring fence 25% of that to go into prevention and early intervention. And you might ask the question of what has a target got to do with localism? Well, at the moment, if I was to take that 80% target for 3 weeks, I think we're probably, and there's data quality issues, I think we're tracking at about 74%. So you might ask, well, is it really that ambitious to go from 74 to 80%? But actually, that's the national average. If you were to go into the data, young people are at about 60%. I guarantee you Māori are less, and if you want to pick a region, say Northland, they're probably even less than that. So just because the national target says 80% and we're meeting it, we're actually going to go into the deeper detail of that data and find out where all the regions are at. And then, of course, that will dictate where we need to provide the support to lift them up to that desired goal. And if we're saying Northland is 20% less, then we need to work out what the local solution for that local need is. So I think there's a real ability within those targets to drive localism as well. The final point I'd make before we get into the panel is I think there's a real opportunity to think differently around what localism is, right? Because we naturally default to geography. And I think you could look at occupation or sector. So you think about the construction sector in New Zealand. Sadly, the largest suicide rate out of any sector in New Zealand, and you think about that sector funding the Mates in Construction program. You know, potentially burly construction workers trained up in suicide prevention techniques that go on site and deliver that support. And of course, as we know in mental health, it's about the therapeutic alliance, right? It's about that connection. You've got to have confidence in that person, trust them, and actually see yourself within them. And that's why you find the construction worker wants to talk to the other construction worker. Where I live in a rural part of New Zealand, the farmer wants to talk to another farmer or someone else in the rural community. And that's why we've got programs like Farm Strong, who train up milk tanker drivers. And you'd ask yourself, why would you train up a milk tanker driver? Well, mental health on a farm quickly translates to animal welfare issues. You got a guy driving in every day, starts to see the welfare of the animals decline, opens up a conversation. Local solution for local needs. And then what I think is a real opportunity, and the reason I was a bit late today, because I just opened the inaugural Mental Health Asian Summit at One Tree Hill, is understanding a community or an ethnic community and what their specific needs are in mental health as well. Quite different. So the stats we learned today, I'd go as far to say that we've done well in New Zealand breaking the barriers down of stigma and discrimination. 98% of people in Asian communities report still they have stigma and discrimination. So clearly we've got a lot to do around that issue in that community as well. So I think there's real opportunities of opening it up, how we define, I think, Oliver, you would say under localism, it's about the place. So what is that place geographically? Is it a sector or an occupation? It is a ethnic community, and another huge opportunity in a community is lived experience as well, and lifting up those local opportunities. So I'm really excited to be part of a government where the Prime Minister has come out and said in a mental health context, he wants to get money out of Wellington. I've announced 3 new services in the last 6 months. None of them were for new funding, from new funding. They were all from unallocated funding sitting in Wellington, right? And so what we're doing is we're getting money out of Wellington to grassroots organisations who know their local communities and can respond to the local issues. And I think that's a real opportunity in mental health. Kia ora koutou. Thank you very much.
Thank you so much, Minister. You'll have an opportunity shortly to ask questions of all 3 of our panellists. Our next speaker is Rachel Brown. She descends from Te Atiawa, Ngāti Mūtanga ki Wharikauri, Kaitahu, Tuahiwi and Kati Māmoe. She is the Chief Executive of the National Hau Ora Coalition. The PHO she leads has 400,000 patients enrolled in over 100 practices, with a specific focus on Māori, Pasifika and high needs populations. She's here today to present on some of the initiatives her organisation has undertaken in the space of mental health.
Kia ora koutou. Ngā mihi mahana kia koutou. I'm just waiting for the presentation. Just like to acknowledge Ngāti Whātua and my friend Tom in the room. First and foremost, Minister Doocey, kia ora, also Mr. Lester Levy, and also Rob Campbell. Just want to acknowledge you, great friend of the NHC. So I just want to acknowledge that, and Cecilia James in the room, fangirling all your business mind. So I just thought I'd do that. I want to thank Michelle as well for the great communication. This is the most communicated symposium, workshop, whatever we're doing here that I've ever been involved in, so the communication along the way. Should I just carry on? Okay, kia ora. I could delegate to my lovely assistant to the right, Jonathan Murray, to push buttons, but it's a great thing about being a CE, you can boss people around. Yeah. Just a little bit about me until it comes up. So I've been at the National Hau Ora Coalition for 5 years, used to lead the service delivery team. Wonderful team looking at local initiatives in different places. We're across four regions. We work across 4 regions, thank you. Waikato, Whanganui, Northland and Tamaki Makaurau. So I've been CE for 2 years. I was asked to step in by the board for a 3-month stint. And I don't know what I did in that 3 months, but ended up with a permanent position, which I'm really proud and privileged to be in. So, kia ora. So looking at local initiatives, I just want to give a little bit of a shout out to, and for those that don't know who NHC is, I'll just give a little plug. So National Hau Ora Coalition is a Māori-led, as you may know, primary health organisation, and our claim to fame, and I suppose we're very proud to say that we're a network organiser. While primary health is a large and important part of our business, we pride ourselves on that bit, organising networks. So we deliver services, but we also take what we've learned over the years, what we've built, what we receive, and we use that to empower and support and enable different providers to deliver services within their own communities. We are very much in favour of utilising local people, local knowledge and local initiatives. We've been doing that for a number of years, and prior to me, people trailblazed the ways to do that. Our vision, so while there's been many changes in the NHC, a new CE, new structure, all those things that come with it, one thing that is steadfast and stayed strong is our moemoeā, our vision, which comes from Dame Tariana Turia and all those that kind of went before us. And our vision is mana whānau, whānau ora. So it is about prosperous whānau, prosperous families that are living well. This is a little bit of kind of where we are in the map of our little world. So Primary Health Network, as Rachel alluded to, we kind of support over 90 clinics, over 400 patients in the North Island, that's kind of based there, and our other work is kind of distributed both in the North and South Islands. Some of the programs highlighted, which I'll talk about, have a dedicated specific focus on mental health. But what I would like to point out is that most of our organisation, the way we work, we have a whole order focus. So it's not just physical health. We do look at the whānau aspect, the environment, spirituality, and other things that come into play. So whether the contract's specified or not, we will do that, and that's the way we work. I just want to give an example. Our Mana Kids program, which started over 10 years ago as a rheumatic fever prevention program. It's now turned into a comprehensive nursing program, which sits in 88 schools in South Auckland and services 34,000 tamariki. So we don't just look at their physical health, their stub toe. We do a lot of throat swabbing, and we train and teach in those throat swabbing to non-clinical workforce to carry that on, so that alleviates the burden from our nurses. We also look at the social determinants of health, the impacts, which includes and increasingly looking at mental health. Our Here Toitu program, which is a return to work program, and some of the other PHOs run that program. We have a focus on wellbeing, so it's supported by MSD and funded, and we have a wellbeing focus in that. So making sure that people are ready to work, that people are well, and then we look at people who are at the risk of losing jobs because of physical and mental health. So there's a big and increasing impact on that. And looking at our healthy housing initiative, so it's not just about housing, it is an impacts on health, how that relates to things like rheumatic fever, overcrowding, and how can we look at the mental health within that home. So while the contract may specify you're looking at housing and kind of doing things around housing, we know the impacts of poor housing on health and hau ora and mental health and wellbeing. So some of the initiatives that have been put in place, so as I said, the contract doesn't specify looking at mental health, but given our workforce has to look at that, we can't leave it alone. We spend quite a bit of money and investment on getting our workforce up to speed. So we give additional training on mental health, making sure that they're equipped, we're giving quality care, we invest in clinical workforce that wraps around them at all different levels. So whether they have a clinical person on the team, whether they wrap around with our clinical team that we have, so we've gone from one of the changes is one clinical director, which everyone should know, that used to be Rawiri McCree-Jansen, everyone's favourite person, some days not. And we've gone for a whole clinical team. So we actually have 3 clinical directors, clinical advisors and director of nursing that sits in this team that wraps around these services as well as our clinics. We also have clinical governance groups and other kind of levels of clinical support that help our initiatives. 3 of the initiatives that I do want to talk about are these ones. Some of you will know some of them, maybe they're called a different name. So Te Tumu Waiora, that looks at our hips and health coaches, health improvement practitioners that are in the clinics. But I want to focus on the community aspect. We had the privilege and the honour of piloting or prototyping one health improvement practitioner in the Manurewa High School, and that went on for a year. And when I talked to the team and what the school's feedback was around that, and what I already know is that it was a really highly valued role. It made an impact in the school, and it didn't only make an impact for the rangatahi and their whānau, it actually made an impact for staff. The pressures they were under, the anxiety, the abuse that they were receiving, it kind of gave them education around coping strategies. It kind of triaged referrals for the team that were already in there. So there were nursing and counselling support in there. They didn't know how to deal with some of these dedicated mental health issues. The health practitioner that went in there taught them that, gave them education sessions and made a big impact. And a big part of that role was relieving stress and anxiety for the staff. And of course that has a ripple effect, a positive ripple effect. And I think of, when we talk about leadership, Lester Levy talked about some quotes around leadership, I think of Simon Sinek, and he says, and I truly believe in this, that when we look after the people who look after the people, it's got to be better. And I think, picking up on the minister's point, localism. Is it geographic? Is it ethnic based? I think localism starts here. You've got to look after your own well-being. You've got to look after the people around you. You've got to have people around there that hold you accountable. Cecilia, I haven't seen you move from your desk for 4 hours. I think you need a cup of tea. Come with me. You need people that hold you accountable, and you need to hold them accountable, because if we can't be well ourselves, how the heck are we going to service the people or look after the people that are in our communities? So just a little plug for me. I think localism starts here. When I look at the program Te Wā Kōrero, this was a 8-week rangatahi mental health program that was developed and designed with whānau, the schools and rangatahi. We learnt some valuable stuff around that program when we implemented it. So we looked at, let's not call it mental health, let's change it and look at the positives and the strengths. So we looked at confidence and resilience building. When we talked to the schools and whānau, what we were noticing, the theme, researcher background, was around connection, identity and belonging. So we built our program around those things, and we started implementing sessions on things like koha. What is koha? What does that mean to you? It's not only about giving a gift, it's about how do you koha your time? How do you koha your attitude? What is it like when you walk into a room? How are you towards your teacher? What are relationships like? What is leadership like? What does leadership mean to you? What are your positive role models? What are your strategies? If we look at wairua, what is your energy, your mood, your feelings, your emotions, and where do you take that? And how does it impact other people? So we used those sort of concepts over an 8-week program, and we noticed the difference. The engagement was huge. You can tell I'm passionate about that. I don't even have to read about it. The engagement was huge from rangatahi, and we wanted whānau engagement, and we knew that would be a bit hard. But because the kids were going home and asking questions, Mum, who was your role model at school? What are your positive influences? Where do I come from? Where is that island? What happens on that island? They were curious about what was happening at school and why these kids wanted to get up and go to school on certain days when this program was on. And also the teachers noticed a significant difference in the kids. So of course we got the naughty kids at first, but we knew that, and we wanted to make a difference in their lives. So that had We had an evaluation done on that, and that was a positive evaluation. And we went from primary school, word got out, the program was working, and then we went into intermediate and high schools. Had to do a little bit of a different focus as we go through the ages, but it was a really good learning curve, and it was really effective. And then our last program that I want to talk about is Te Kaupapa, and I do need to acknowledge the learnings from Mark and Dai Kōpua and the Mahi Atua program. So this has evolved out of their kind of leadership and program. So this program does the same thing. We work with different people using kaupapa Māori concepts, and we change it to tailor it to the community using localised approaches, local people. So this program aims to hold and respond to whānau living with mental health and addictions. And the program is culturally led, culturally supported, clinically supported, and utilises Indigenous approaches. And just want to acknowledge Ngāti Whātua as well, because they are part of our one of our providers that present that program and lead that program in their communities as well. Unfortunately, all good things do come to an end, so a couple of those programs have their funding has come to an end, but what we learn at the NHC is that we take those successful elements and we put them into other programs, so we never lose sight of what's successful for our whānau, for our communities. So making things work, and I think Mr. Levy said it, you can't always rely on government initiatives or government funding, so we kind of invest and reinvest, whether it's resource, money, time, to try and make this work. We know what works for our communities. They know what works. They're the experts. It's funny putting these slides in 2 weeks ago when you're supposed to kind of change it. Anyway, if we look at impacts and outcomes for us, what works, as already been kind of alluded to, is around cultural concordance. So incorporating people who mirror and understand the populations that we serve. They usually come from the communities, so they are invested and passionate. And it is about, for us as a network organiser, is building the capacity and capability within these communities. So it's sustainable, and so they learn, they can train the trainer, have mentors, tōkana teina approach, as long as they're well supported and well resourced as much as we can. If we look at social investment model and social return on investment, we've had various analysis done for a number of programs using different methods and models. Impact Lab has been great. We've had external evaluations for our programs. We also have a research centre within NHC, so we use the research and our insights from our More Heal data and IT platform. So we have kind of internal capability that looks at, key themes, the analysis, and we kind of are able to kind of target where the need is. So we know where we're failing or limiting, and we also know where our strengths are. So we're grateful that we have been set up and we have some of that infrastructure. Some of the main things that come out of the evaluations and et cetera that's been done around mental health is around, and it's not rocket science, we all know it's continuity of care, but also continuity of care. It's also around navigating the health system as it is. And the other thing that's come out is access to other services and approaches that work at a local level for them. When we look at data, Lester talked about research. We need to use the data that we have, but also we need to interpret the data. For us, it's about interpreting it in a strengths-based approach. So for us at NHC, we're looking through our data system, moving beyond kind of current primary healthcare data of sickness or illness or management to kind of person whānau-centred strengths-based data. So capturing different models, enabling the use of whole person data, looking at their strengths, their aspirations, what's working well in your life. So often, especially for our people, we're looking at the deficits. And actually there are some really strong positive influences in their life. We just don't capture that. And then we can kind of look at that, we're still tweaking this, and aggregate that at a population level. So what we know, and this will be my last bit, is that looking at prevention and doing things well in the community and in primary care in the space, it helps us reduce the pressure and burden on our whānau, but also on our secondary services. And we've seen the impacts of that through different analysis. And I just want to finish off saying that what Mr. Levy was saying is around when health impacts you or ill health impacts you, you certainly have a different perspective of it. And I'm speaking from a mum that had a child with a cancerous brain tumour, and repeatedly that happened again, and so went through Starship, went through rehabilitation, chemo, radiation for years and years and years. So understanding that pathway. The positive out of that, and here's a positive, I did a PhD on it. So that's what you do when, things go, you kind of want to get some evidence and do a PhD. So just doing a plug that really for local initiatives, we believe in them, building the capacity of our local providers and working with iwi and having those relationships. I think for NHC, we have set up to put a PO in the ground, put our stake in the ground earlier on. What I've learnt in my time is you need to take that up, widen it out and welcome people, and we have to work together, and we're willing to do that. So kia ora koutou katoa.
Thank you, Rachel. Appreciate your commentary. We will have some questions, as I mentioned, at the end. Our next speaker is Dr. Frances Hughes, who will speak to how technology can help us in the mental health space. She has essentially an alphabet of letters after her name, such as her achievements. She is a global health sector leader based here. She was the CEO of the International Council of Nurses in Geneva. She's held professional roles in the Pacific, in Queensland, in Philadelphia, and here. She is a specialist in data and technology and is the co-founder of To Know Me, a Swiss-based mission-driven company focused on creating easy-to-use technology-enabled tools. Frances is a senior research fellow at the Centre for Health Outcomes and Policy, the University of Pennsylvania. Please welcome Dr. Frances Hughes.
Kia ora, ko Frances Hughes ahau. It's indeed wonderful to be back at this forum, so I do thank the organisers for inviting me. As you can see, my background is I'm a clinician, I'm a registered nurse, and I have worked with and for 18 different countries around the world. And I also have been around many countries where there's been lots of disasters. Many of that has led to some of my academic studies. But I look back at COVID and what occurred in COVID, and at that stage I was a clinical lead in a major aged care organisation in New Zealand, and I saw a glimpse of us being enabled to use technology in a very different way. But I have to say it didn't last long. The door shut very quickly on many of the things that we actually wanted to see that would have actually assisted many of our consumers to have better access. The rollout of telehealth. During COVID, we didn't have to take people to outpatients appointments. We had ability to have virtual health in our facilities, and many of those people were able to see consultants directly and get care. Now, many of that has stopped. People are still driving up motorways, cluttering up car parks to go to outpatients. In fact, my home base is in Taupo, and last week a friend of mine had a cardiac event and was to see a cardiologist in Lakes. They drove an hour up I won't say it's a motorway, up State Highway 1 with many cones, to go to Lakes Hospital. When they got to Lakes, they were put in a room, and they had a virtual telehealth with a cardiologist from Wellington. Now, she came out and she said, my husband drove me up, why did I have to go to Lakes? Oh, you have to, it's a privacy issue, they were told. One of the biggest issues around defining innovation in healthcare is that we know the technology, we know the science that's backing this, we know that it involves social innovation, scientific innovation and business innovation, but somehow or other we do not have the operating model. We do not have the enablers to get the system going. And I work in a world where I come across lots of technology every day, and the power to the consumer cannot be understated. the importance of the consumers being able to have a bigger control in what they do in their life and their health outcome is part of us dealing with what Lester talked about was funding and workforce. We'll never be able to grapple that unless we start liberating this sector. Technology is both an enabler and capable of accelerating initiatives to these positive health outcomes that we need. But it also holds potential to produce unanticipated consequences. So we cannot be naive enough to think that, for example, misuse or overuse, just like cell phones we have in schools and now we, thank goodness, have banned them, can actually exacerbate predispositions. It can cause that anxiety, which then is not managed, which leads to those access high-level mental disorders. So there is a link. But do not be afraid. We need to be bold and courageous and understand the risks. And we need to keep that scientific evidence-based research and impact along with every new initiative that comes to mind. Saying that, the startup sector has begun to make a furore into the world of mental health, a bit focusing primarily on mindfulness and talking therapy apps. But the venture capitalists in this world that are looking at apps and technology to assist in health is amazing. In fact, some would call it the Wild West. While these are useful first steps to get involved with mindfulness and talking therapies, we need industry and consumers to have greater involvement. We need a new operating framework to ensure that these disruptive approaches and focus on new technologies will actually improve the offerings for consumers. They will actually help us to get better, not just allow another thing of compliance around us. There's always need to innovate in less attention-grabbing ways, particularly in conducting research and better understanding mental health and mental illness. So prevention is what needs to be key. The enabling technologies need to be assisting us to produce and understand and help deliver protective practices and protective systems for our consumers. One such example is the Wobot. Wobot was developed by Stanford researchers, and it actually enables CBT, guided self-help, and natural language processes for consumers. This is one of the few technologies that's actually had quite a big randomised control study. And it was found that when consumers used this technology, that there was significant reduction in the symptoms of depressions within 2 weeks versus controls. These apps and this technology is widely out there at the moment. What's important for all of us to understand is that the technology isn't on itself a panacea. We need to partner. We need to make sure that the equity companies which are sloshing around the world at the moment looking for something to fund and innovate, that there is good frameworks around that. And this goes back to what is the role then of governments, what is the role of organisations, and also for me, professional practitioners who are faced with looking at technology every day. This week alone, in another piece of work that I've been doing, I was faced with looking at reviewing an assessment which was done by a clinical psychologist overseas for a New Zealand family sitting in Auckland, using technology that no one had seen before, using tools which looked like they were the tools that we want in our guidelines for assessment. And there we have a complexity of no ground rules for this kind of tsunami of issues that is facing practitioners. As a practitioner myself, it's really important that we have models of care that embrace this technology, that we have regulatory bodies that allow for technology and for practitioners to work in a different way. We have a workforce shortage, but in some countries we have oversupply of some of these workforce practitioners. But we are not allowed to use those practitioners lawfully in New Zealand through telehealth means. So, in summary, for me, The most important thing is to liberate our consumers and allow our consumers to have greater access to information in a discerning manner with qualified health practitioners. We cannot keep up the insatiable demand for our services. We cannot build the workforce fast enough. We can create new roles, but that's not going to deliver. We can only address financial issues and in the combination of workforce issues if we allow technology and systems and an operating model within a new model of care for delivery for New Zealanders. Having worked in Queensland in the public sector for 5 years, working with outbacks and rural sector, which are truly rural, without technology and without assistance of a change in a regulatory framework, many of that community, and particularly in the mining industry, which invested a great deal of money, would not have been able to deliver primary care, let alone mental health. So I'm a great promoter of health literacy. I strongly believe in that the consumers deserve to be able to determine the access and where they want to access services. But we cannot keep building buildings. We must enable the research and the technology and partnerships we have today to help us liberate this system. And I do wish Lester Levy well. Thank you very much.
Thank you so much. Thank you all. I'm going to come and circle around, and I'm happy to take questions if anybody has any questions. Michelle, I think, is also circling if anyone has some questions to put to... We've got... Oh, of course. I should have been up front. Here we go.
Sorry, so obviously we've got a tsunami of issues with mental health coming through with our young people, right? So probably in particular from you, Minister Doocey, I'd really like to understand our approach that we're going to take moving forward in terms of social media and our young people.
Yeah, look, a very good question, and I think what we've got to probably join up is the emotion, the politics with the science and the evidence base. And to use a term we speak more in the environmental context, I'm not sure the science is settled yet. Clearly we're seeing some jurisdictions like America move quite quickly, some states in Australia. But the advice I've got is we just need to learn more. And why I say that is because it's a bit double-edged, right? So we all know the stories of young people who are spending too much time on social media and what they're being exposed to and how harmful that might be. I suppose we've got to understand causal and causal links. Is the depression and all the anxiety stemmed from social media, or has someone have the depression and anxiety which leads them to excessive use of social media? And also, some would agree social media is a great way of breaking down barriers for people who are quite isolated and providing them with mental health promotion and education and resilience skills training. It's something we're definitely keen to look at. The Prime Minister himself is interested in us really grappling with this issue as a country. You've seen us at a first step around banning cell phones in schools, and I think we need to do a lot more to truly understand the impact on social media. One point I would say, though, as a politician, we also need to have a conversation about what is the role of government, because, of course, a parent and a family can decide today if they want to stop their young one using social media. So we need to step that through as well. The final point I'd make is a bit more of a light-hearted one, but I remember in England when the government decided to ban unhealthy lunches, because of course they have all the school lunches, and they got Jamie Oliver in to do the healthy menu, right? And as only the Brits can do, the 6 o'clock news was filled of pictures of parents liberating their children by stuffing takeaway food through the gates of the school to ensure they could have that for their school lunch. So I just think we've got to be mindful as we step through that as well. I don't know if you'd like to add anything to that. You're a bit in the technology space, Frances.
Yeah, I think that my view is that the government has a role in protection and regulation, but it needs to ensure that it's a light touch where it's needed and a stronger touch where there's greater risk. It's all about risk. And I think if we did actually better risk analysis, we most probably wouldn't stop some of the things that we have stopped occurring, because often it's about people put up their hand, and in the clinical world they say it's unsafe, we can't do it. And we need to challenge that kind of thinking, because until we challenge most of the things that we did 20 years ago, we stopped. When I trained as a nurse, people stayed in hospital for 2 weeks to have a cholecystectomy. Now they have it in a chair in a ambulatory theatre. So, you know, I think we've just got to make sure that we have good risk systems and understand it, and stop putting up the shroud of patient safety, because sometimes it's actually the best thing we can do is to liberate and allow people to have decisions and not stop the school lunches, really.
Rachel Brown, I'll put a question to you. You have a PHO which looks after 400,000 patients, predominantly very high needs population. What's the greatest challenge you face in trying to deliver mental health care to Māori, to Pacifica, and to those high needs populations?
I think there's a number of contributing factors. There is the funding issue, there is the workforce issue, but as the coordinated approach to sustainability, whether that's funding or workforce, it's education and letting people in localised areas do what they need to do under guidance and clinical safety, and having the support around them. So the hardest bit is, I think, is the coordinated approach, because you know, people go in, they already have a mindset, they already have a way that they're trained, but actually they're not trained in the localised approach or with those communities. So it's the attitudes, behaviours really that we find hard.
If you talk about, if we look at the social investment model, what is fuelling and what is the trajectory of the mental health challenges that you're seeing? I'm talking about on the front line.
For us, what we're seeing is that escalating, and so we need some reassurance and sustainability. We're trying to do that in-house as well. We're not trying to solely rely on government. You'll be pleased to know, you will be relieved. So we're trying to get local solutions using kaupapa Māori approaches, specific approaches, things that work in those communities. Otherwise, it's escalating. So we're trying to reduce and minimise and mitigate that as much as possible.
Minister, you've got 2.6 billion, you said. Lester Levy spoke earlier and said he felt confident that you could deliver within your existing resources what he wants to deliver. Can you, do you think?
Well, I think we've got to have a really good go, and that's part of my role, to look under the hood and see where we're spending that money. Look, can I be really candid, and I don't think it will surprise many in this room. When I talk to officials to understand where the 2.6 billion has been spent, I get back commentary like we're actually not sure, right? Because they've amalgamated 20 budgets and commissioning plans, and they're still working through. And as we know in healthcare, it's historical incrementalism, isn't it, right? Just everything gets added on. And actually, we've got to understand where that money is being spent, how it aligns with the government priorities, but also, ultimately, is it delivering? And is it effective? And can it be reprioritised into areas that can be more effective? So when we look at Māori, who are sadly overrepresented in poor mental health statistics, suicide rates, just quite frankly, we need to do a lot more in kaupapa Māori mental health services by Māori for everyone, culturally trained and appropriate workforce. That's where we need to go. And then you can start looking at other areas which I articulated in my speech as well.
Question here from Mr. Ian McRae.
Question for Minister Doocey. So the question I have, you talked about devolution, actually subsidiarity, which I think is a great idea. The question for you is how far and fast can you go? Because if you look back in the past, we had the most innovative period we had was the Simon Upton period. Now, they had a few other little issues. In fact, your millennials in the audience won't know what I'm talking about, but never mind. At the year 2000, New Zealand led the world in innovation. we had the very best IT infrastructure in the world. And then we gradually merged, consolidated. We went to 4 regions. And that really slowed up innovation. Now we have 1 region, Wellington, and talking about innovation when one organisation makes all the decisions is just a joke, because there's only one customer. They want to do everything themselves. The procurement is very opaque. So the question for you really is, how far and fast are you going to go? You announced 4 regions, but I would suggest probably that's not far enough. You want to have coal-face organisations wanting to buy a mental health application or whatever and have the budget and the ability to do it.
Yeah.
Today, that's not true.
Yeah, and that's correct. And I suppose when you look at that term subsidiarity, it is going to the lowest level you can for decision making, accountability and funding. And like you say, we start off at a high level where we're quite centralised now. Look, I suppose there'll be a common view in the room around DHBs, and I don't think anyone would really try to defend them too much around the postcode lottery. But what we lost in mental health is regional ring fence funding that was able then to be looked at around the needs of that community and then responded to as well. So I suppose we're looking at national contracts, which would be quite rightly for potentially, my example was ED inpatients, where you need very few of them, you would commission them. Then we've got the next step down now, which is the 4 regions. But the reason I raised under subsidiarity of the council level is that when you look at the whole of my island, the mainland, being 1 region, that's a big geographical region. And so we have got the potential when you look at potential council jurisdictions as well, and that's what we'd be working through. And to your point, I mean, how far you're prepared to go. Look, to be very candid, I'm going to try a lot of stuff. It's a new role. I won't actually get everything right, but you've got to try stuff, right? And I'm less of needing to know everything's going to be perfect before we'll trial it. And that's part of what we've announced with the Innovation Fund, right? We want to back local solutions. We want to trial stuff. Some will fly, some won't, but then you learned about what stuff worked and then you've backed that even more. So that's what we're going to try.
2 more questions.
Yeah, well, that's a fair point. But another principle I raised in my speech was that national consistency and local flexibility. So you're right. Okay. You can say what is that national standard and then get that local response, which DHBs were arguably supposed to deliver.
3 quick questions to come. Questions, crucial part of question is a question, ladies and gentlemen. Yes, sir.
Joe Scott Jones Tokuinga. I'm a GP and clinical lead of another PHO in the country. One of the things that you raised, Frances, was about regulation and potentially enabling overseas trained people to provide services within New Zealand. One of the things that we see in terms of putting a barrier to innovation are is the inertia of the structures that we have, our College of GPs, our Medical Council of New Zealand, in allowing people like nurse practitioners to extend their roles, nurses to extend their roles, community health workers to extend their roles, to say nothing of this sort of innovation. How are you going to address the inertia that's in the system around that sort of regulation? Keeping people safe, but really speeding us all up.
Yeah. So where I'd start, right, is the last government promised a lot, announced a lot of money, which probably as a minister is the easiest part, and then very little translated onto the ground, I would argue. That's my point. People can have different views. Said to me, it's an implementation issue, right? So what I've done is I've found a crack person, and her name is Frances Hughes. And I've got Frances Hughes on board. It's a bit like, old school, the A-team, they were a crack team. And Frances and her team sit outside MOH and Health New Zealand as independents to triangulate the information and actually report back to me around implementation issues. I don't know if you want to talk to that, Frances?
Yeah. Kia ora. So we're called the Assurance Group, I think we are, Minister. And we're kind of the monitors of the monitors, if you want to see it like that. The critical friend, I call it, when I talk to the Ministry and to Hau Ora Health New Zealand and the Mental Health and Wellbeing Commission. So our role is to say, how do we know that you're doing what you said you're doing? How do we know that you're delivering on the priorities and the KPIs? And one of those big areas is the workforce, which you rightly say. I mean, I put my hand up. I have been battling some of this stuff for over 20 years. I did all the policy work and fought the battles with significant scars in the late 1990s and early 2000 around nurse practitioners, nurse prescribing, pharmacy prescribers, paramedics, and it's hard. The status quo is a big magnet and keeps things very tight. But you're absolutely right. As long as you have a good operating and risk framework, we must be able to enable practitioners who can demonstrate competency and have appropriate regulatory things around them. I do not see that in the current some of our boards at the moment. There's a great deal of patch protection which still continues, and that goes in many ways with allied health and nursing and midwifery and everything else. So the main thing is that we do need to liberate the workforce for mental health. As the Minister said, we will be monitoring to see what they're doing. We've spent millions and billions on workforce in New Zealand, and to be honest, it just feels like we've got nowhere. So thank you for raising it.
Can I just say, as a quick win, Physician Associates, that's stuck, and I don't really understand why it's stuck. If you can unstick it, I'd be great.
What we'll do is we have to leave it there. We have run out of time. Thank you all for your questions. I think the Minister has to go, but Rachel Brown, Frances Hughes will be around to have a chat with you all in the break. But on our panel on localism strategies to create solutions for mental health, Minister Matt Doocey, Rachel Brown, Dr. Frances Hughes, thank you all very much.